I'm an African woman. 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 African woman. I'm an African woman. I'm an African woman. I'm an African woman.
My name is Temi Tokwe Ilori. I'm a Nigerian. I was trained in the University College Hospital, Nigeria. I am presently a bureaucrat. I'm in government. I'm the Commissioner for Health in my state, Osun, and I'm also the chairman of the HIV agency control for HIV agency in my state. So that is what I do now. But I must say that my training as a family physician has really, prepared me for this job I'm doing now.
Jane Francis Namatogo, a 39-year-old female Ugandan family physician. I qualified in 2007 and I've been working with the Department of Family Medicine since 2004.
So my name is Magdalena. I'm 48 years old. I originate from Bulgaria and I work and live in South Africa in the last 20 years. I did my undergraduate study in Bulgaria and emigrated to South Africa in 1996. Joined the family medicine program in 2008 and finished the program last year.
My name is Martha Makwero. I graduated as a family physician 2 years ago from South Africa, and I got an extra qualification in women's health, which is also a postgraduate diploma.
I'm a third-year family medicine registrar, currently with the University of Witwatersrand, and this is based in Johannesburg, South Africa. I'm interested in reading, arts, I like painting.
My name is Abimbola Silva. I'm a consultant family physician. I'm married with 3 children. I live in Nigeria. I work in Nigeria. I obtained my degree as a family physician in University College Hospital 2 years ago, and I have been practicing as a family physician since then.
Physician, tough question. Well, I guess I want to be everything to everybody. My interests cut across all generations. I want to treat the young. I want to heal the old. I want to be there for the mothers and the children. So I like the generality of the discipline.
After my first degree, I thought patients are interested in a diagnosis. But after some time, I realized patients need more than just a diagnosis. And when I looked around all the programs, I thought family physicians would cater for the other things that patients were interested in. So I thought that's a good discipline for me to do so that I can cater for both their medical and psychosocial issues.
During my undergraduate study, I was thinking how I can combine being in help of children and adults and being a surgeon meanwhile, and that in that time it was really impossible. But when I heard about the family medicine, that struck me very much, and I decided, yes, that's it, that's for me. So when I joined the program, I really didn't know what I can expect, but throughout the study I was very excited, and really now in my work I enjoy it very much.
That's a good question, because I never considered this in my undergraduate, because I never knew about it. However, I found myself, my comfort level declining when I sit in an outpatient department, where when some patients come, then I would feel some discomfort, uneasiness and feeling of incompetence. But then after studying family medicine, I found my level of comfort getting better and better, my level of confidence in managing these patients. So I said this is what I really want to be, because I get intrigued by working in rural areas and getting my services to people who need it most. And that's where you need, in the rural areas, I can't find specialists. I would really have to do most of the things by myself, and that's why I find family medicine quite exciting.
I think it appeals to me, the holistic approach to patient care and patient-centeredness, because I think ultimately, I think the patients would be the provider of all the answers to their own problems, and I think self-realization, we can bring about that through family medicine.
I wanted to be a family physician because I wanted to be able to take care of everyone, the children, the mothers, the grandmothers, the grandfathers, and I think I'm happily doing that as a family physician.
Tell us about your practice in Africa. Well, as we know, Africa, we have challenges, but being in government, I'm more involved with policy making, strategic planning, trying to population medicine. So that is really my involvement presently, implementing policies, formulating policies, ensuring that these policies are actually carried out, and I'm working more closely with the grassroots population, the underserved population.
I am the chairperson of the department presently. I've been for the last 1.5 years, and I basically have a staff of about 7 family physicians, and postgraduates about, for now I have 8, both first, second and third year.
I'm currently based at a level 1 hospital. This is in the West Rand district in South Africa, and it's obviously we focused on providing care in a public service hospital. So chiefly those are patients that are uninsured, and we care for these patients.
Well, I think like most other women all over the world, the multitask role, the fact of being looked at as a secondary, as a second citizen, not being recognized. I practice in a male-dominated world, so you have to really prove yourself that you've got what it takes to be where you are.
Practice in my country is not ideal yet. Where I practice is more of outpatient, and there's limited continuity of care. Of course, in the private sector, it's much more achieved, but in the public sector, it's not very ideal. Although we are trying to work towards that. Even the postings of the graduates are not sometimes the ideal places. Sometimes they are posted at regional referral hospitals when we would like them to be at district hospitals where there are no specialists. But for now, we are working with that.
South Africa is not an easy task because it's a lot of challenges, and especially in the public sector, in the primary health care. And you have to balance between your family and your patients and their families as well, and being their help. And the workload, you have to face it. So that's a big challenge in work. Cooperating between the work and the family, that's another challenge. And sometimes I get some criticism from my family, being mostly at work and preoccupied with the patients and workload and so on. But I love it. I wouldn't be imagining something else that I can do in my profession and in my life.
Family medicine in Africa is about, apart from the general practice work, you have a lot of surgical skills and obstetrical skills, which are very, exciting and challenging at times. And with that, usually also there's lack of skill and personnel at district rural level. So I find myself, working long hours because sometimes you're the only one who can provide that skill. And because of that, there's long hours that you put in, and also being a wife, being a mother, you have to balance up all those roles and still do your work. The other thing is sometimes when you find a problem that is an emergency, but you do not have adequate skills for that. For example, you have to do life-saving amputation. Sometimes you just do what you can do to save a life. So that's what is challenging and yet exciting at the same time.
I think indeed there is quite a few registrars in family medicine with the University of Witwatersrand, and I think it is a challenge to promote family medicine appealing to females. I think that would be a challenge, and I think in particular focusing and promoting women's health. And for me, I think in particular is intimate partner violence. I think in South Africa we are living in a patriarchal society, and challenging these social norms is a challenge. And I think IPV is something that we need to be addressing and promoting women's health in this regard.
It's a very challenging thing to work in Africa as a family physician. First, mainly because there's a lot of things we have read in the books, and then you may not have all the facilities that you think you need to be able to give your patient the best, but we try, we do what we can. Some of the challenges, like I said, is when you don't have facilities and materials that you require to be able to help the patient the best way you could, especially finances. There are many times when you know that you can do something for a patient, but then it doesn't have the money to do it because most of our healthcare is out of pocket. Very little is done by the government by way of financing health, but we do what we can, like I said, and we make the best out of every situation that we are faced with.
Well, I believe the future is bright, especially for women. We have lots of women in leadership now. Even at the Wonca level, our president-elect is a woman, and we have women leaders, and women at large and all that. So the women are beginning to have a voice. I believe in the very near future, more women are going to hold leadership roles, and I think this will translate to better society. And I look forward to an AIDS-free society, a society where we are all equal, irrespective of our sex, irrespective of our race and religion.
We are going to start an undergraduate family medicine clerkship in 2014. I suppose we are going to learn a lot of things, and of course it will give us more exposure for the undergraduates, so that they can look at it as one of the specialities they can take on after their first degree. Some other things exciting include many other African countries are taking on family medicine, which gives us a big community of practice, and we can share issues and also have more identification, especially as far as our governments are concerned, to look upon their neighbors. They have family medicine, so they won't think that this is something strange and abnormal. So that's exciting. And I don't know how that is going to work out, but I think it's going to give us a lot of momentum. And in teaching institutions, it gives us a lot of identity. If you want to have like an external examiner, it's easy to work with the other universities that also have the discipline, unlike before. Something else exciting is that we are really trying to see how we can encourage government to change the present name for the graduates of the program from consultant public health specialist to a family physician, so that even when they are mentoring students out there or mentoring graduates for first degree, the graduates don't start thinking that this person did public health. They will know that this person really did family medicine. That is something that we are realizing is a very big block to the guys who are coming in as enrolling for the program.
To be able to be recognized by the patients, mainly because that is the big reward, the patient's reward.
I'm excited about the future of family medicine in a sense that the way you see patients is now different. You don't no longer see them as cases or diseases or sicknesses or exciting, patients, but you see them as people with social lives, social determinants to their illnesses. So that's what excites me to introduce family medicine in our medical schools, that people can start looking at patients in a different perspective and managing them holistically.
I think that changing attitudes towards patient care, I think, be it pharmaceutical, single drug treatment in ARVs, I think that would be excellent. And also encouraging the patient-centered approach. I think ultimately patients advocate their own health and promote their health as well. I think including them in this is very, very important. So that excites me.
I'm excited about the future because for one, there's a lot of enlightenment now and awareness about women issues, which has always been a problem in Africa. Where the women are of course second-class citizens, and you don't get to that some things even you can't help because you're not supposed to talk about it. You're not supposed to do anything about it. And as a doctor, there's very little. You have your limits. In other societies, there might be, for example, domestic violence. There might be other circumstances where there are bodies that would take over from you once you identify those that are experiencing it. But there's very little of such things in Nigeria, in Africa generally. But I'm excited now about the future because more and more people are talking about domestic violence issues and it's becoming a topical issue. More help seems to be coming.
When we look at the woman family physician in Africa, first and foremost, they need to become visible. Okay? So I think there's a need for the African woman family physician to link up with fellow colleagues, form organizations that can then give them a voice that may influence policy, influence practice, and influence education and lifestyles. So there is need for the women, first of all, to get together. So my personal perspective is that the women need to draw from their own strengths, first of all, before they can then ask for help or additional strength from outside. And there is a lot of strength in every woman.
Nowadays that females are getting into higher powers, it looks as if women in Africa are trying to improve the status of the health and also to improve the educational values. The way forward into this system is that women will be taking more positions and hopefully be more organized, and would also touch on issues where females have problems and to solve those problems.
For me, the priority is developing leadership in African family doctors, female family doctors, and giving them opportunities to come to leadership position, to be able to advocate for issues relating to women and health and other social, issues. That's key for me. And so there's need also to begin to incorporate into our pre-graduate and postgraduate training curriculum around gender issues.
Oh yeah, I've got a kinky hair, kinky hair. D-U-M, baby.